Good morning. It's Wednesday, November the 24th. We're broadcasting live here in the Dahl Simons Family Studio. Welcome back to Open Mics with Dr. Stites. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Thanks for also joining us on Facebook and YouTube. Today, it's estimated 47 million antibiotic courses each year are prescribed for infections that don't need antibiotics here in the United States. Doctors' offices, emergency departments, urgent care clinics, all of those places can be the site of where that prescription could take place. That's about 30% of all antibiotics prescribed. All of this according to the CDC. Today we're going to talk about the problems it's causing right here in Kansas. So make sure to get your questions sent in to us on YouTube, Facebook, Twitter, and the Medical News Network. You find links to those right here on your screen. We also have some pretty great guests, but first I'm going to turn to Dr. Dana Hawkinson, who's going to join us with our numbers.
Yeah, hey. Numbers are stable, luckily going into this holiday. 17 active infections with 7 in the ICU and 1 on the ventilator. We still have 3 fully vaccinated patients of those 17 active infections and 16 additional patients in that recovery period as well. So a total of 33. But, Steve, our numbers have just been staying down. High teens, low 20s. Luckily, it's more of the high teens. Certainly, we would like less infections in the hospital, but we have given over 100,000 doses of vaccine here at the health system.
I love that number.
News
That's
yesterday,
good.
so
that was awesome. Good. Well done. And we know we are seeing some concerning trends nationally. We got a couple of graphs I'd like to talk with you all about for just a moment this morning. This is showing us the 7-day moving average of new COVID-19 cases here in the metropolitan area. What you see is the line that has the Kansas City portion of that, our metropolitan area. It's kind of jumped up. Look at the uptick in new cases here. And remember a few weeks ago we started seeing the uptick in wastewater, which usually predicts the uptick in new caseload by about 2 to 4 weeks, which predicts an uptick in hospitalizations by 2 to 4 weeks. And you can see that happening across our Kansas City area, the Kansas area. Time to be a little bit nervous around those things. We also know nationally that whereas the Midwest had gone down on a trend, the Midwest is popping up. The Northeast is popping up. The South is starting to edge back up again. The Far West seems to be declining after a recent surge. So I think what we know is that whenever masking starts to be people back off, whenever we start seeing people not exercising the same degree of caution, even though the U.S. has given a lot of vaccination doses, about 65 to 70% of Americans have had at least one shot, we're still vulnerable. We can still see new cases. We still have a very large population of unvaccinated folk, and what that means is we have a large population of vulnerable people. And as we said to you just a little while ago, out of our hospitalization, the acute care cases today, 14 are unvaccinated, 4 are vaccinated. And many times our vaccinated people are being found on random admission testing. They're here for another reason. They're not really an acute COVID illness. So it's a different, we just have to be very cognizant of what's happening, especially here in our metropolitan area. Masks are off. People are back gathering again indoors. Hats off, though, to Wyandotte County, who, at least in our humble opinion, because they've extended their mask mandate to January the 6th, I think that was a really great move. Let's see if there are any reporter questions out there today. All right, I'm not hearing any. All right, so don't go too far, Dr. Hawk, because I know we're going to have community questions for you. This use of antibiotics is a big deal. So this week is Antibiotic Wisely Week use in Kansas. The governor issued a proclamation about that. According to state health officials, Kansas is the 8th highest antibiotic prescribing state with 904 antibiotic prescriptions per 1,000 of the population. We're going to turn to our guest, Dr. Steve Stimson, pulmonary critical care medicine sleep specialist, president of the American College of Chest Physicians. Wow, okay, just because you're Mr. Big Pants here. Oh, my goodness. Dr. Simpson and I go back a very long way. He's also...
My waist size is not your business, Dr. Stites.
He also does work that he can describe better for Medicare than I can, and does both work nationally, does a lot of work here, and is a well-established author, and has always taken a very rational approach to how do we distribute care, and was actually one of the authors of rationing care in the state of Kansas a few years back. We're also joined again by Dr. Steve Lauer, one of our outstanding pediatricians, and who's the vice chair of pediatrics or some such thing, and the site director here at KU. I've known Steve for a long time too. He's an outstanding general pediatrician. He's for those of us listening to our show know that he's frequently on. Okay, now Alexis, I just heard you have a community question. You want to give that to us? You're on mute, Alexis. It's only the second year. Don't worry about it.
Getting off to a great start this morning. Okay, I actually have a reporter question. This one was emailed in from Rebecca. Can you hear me all right?
We got you.
Okay. Rebecca at KMBC has a question. The Johnson County Sheriff Hayden announced a partnership between the Sheriff's Office and a biotech innovation company called Antibiotics. They have something called the Antibiotic score. It's an antibody test that the sheriff is going to be using, offering for free to all employees at the Johnson County Sheriff's Office. It will test the T cell level, indicating a person's, according to the sheriff, COVID-19 immunity. So he's offering this blood draw to all the employees for free. Rebecca wants to know, one, is this a viable resource for testing COVID-19 immunity? How do you feel about it from a science and public health perspective? And should private citizens be using this kind of test now? Is this a viable indicator as to whether or not that you are immune to COVID-19?
Yeah, I know the sheriff's probably trying to do the right thing for his folks, but unfortunately, Hawkeye, there's just not enough data out there to believe one biotech company has solved the riddle of whether or not you have immunity to COVID-19.
Yeah, I mean, I think we have to understand that if you've been vaccinated or even if you've been infected, there really is no role or no guidance to get tested on antibodies for immunity. Again, we know the human immune system. We know antibodies do decrease and wane, and so you have high initial antibodies after infection or after vaccination, and those go down. You know, looking at some of this on the Antibiotics score, it's really difficult to say exactly what it is. To me, it looks like it's only an antibody test, so I'm not sure about the T cell immunity, but again, I could be wrong. But just looking at their website, it looks like they try to test neutralizing antibodies. But again, for somebody who's been vaccinated, there really is no need to necessarily do this. If you have been infected in the past, again, I'm not sure what else this is going to show other than you have had exposure. And so, you know, as far as testing for immunity, may it work? It might, but again, there's no official guidance that we really know and understand how to use these tests. As of right now, even though the data is coming in and we are learning more about the correlate of protection, meaning what level of antibody or what level of T cell immunity does protect you from getting the infection, from getting any symptomatic disease, or from having a risk of going to the hospital. We still don't fully understand that, but we are learning more every day. So again, I think going back to your point, he's trying to do the right thing, but there is no official guidance that people really need to be doing this, and especially if you've been vaccinated, I don't see a real need to do this.
And I would just say, I think, and I appreciate somebody trying to figure out whether or not their employees are safe.
Yeah.
I think that's a well-intentioned deal. But I would turn toward the infectious disease experts at the CDC, the FDA, and other places who spend their lives researching these questions to determine if what is being marketed by a biotech company as able to measure your level of immunity has meaning. Right? I can tell you what your number of antibodies you have is, and we can go test for that. That's fine. That's not a new news. The question is, does that have meaning? And we don't know if it has meaning. We think there's some early indications and some rough correlation between those who have more antibodies and what your outcomes are. But there's a lot of other questions besides just your number of antibodies. As, for example, do you have a history of kidney disease? Have you been transplanted? What's your heart like? How healthy are you? What's your weight? What's your A1C? Your measurement of your diabetes. All those things matter. It's not just a simple number. And and I think where those of us who practice in this space every single day struggle with these individual tests is people want to look at that number and say, I've got it or I don't. The reality is it's much more complicated than that. And what those tech companies can't tell you is how their number compares to the actual patient outcomes with lots of other variables like the ones we just mentioned. And so to say you're healthy or not healthy, you're safe or unsafe, that is simply not true.
Yeah.
And you just can't draw that correlate, I think. So I would discourage people from going to find that. And even though I think people are well motivated, we all want to find that answer. Unfortunately, the answer is not going to be simple. It's going to be complex. And that's why you turn to people like the CDC and the FDA to help it, because you're asking people who have spent their entire lives practicing in this space and trying to figure these questions
And
out.
I think the other point to that, too, is we're looking at time from vaccination or time from infection. If you're checking any antibody test, it is going to be higher in that first 2 or 3 months after a vaccination or infection, and then it is going to decrease anyways. But that doesn't mean you necessarily have less immunity per se, especially against what the vaccine is trying to protect you against, and that's going to the hospital, going to the ICU, and dying, because you have that memory function of your B cells and your T cells that are continuing to circulate and look for any other exposure to the virus.
Yep, and we know there's 5, 6, 7 more layers of immunity besides an antibody level that are critically important and what keep us safe. And actually, also what goes wrong when we get really critically ill from COVID-19 and we have all these terrible syndromes afterwards. So it's both what keeps us safe and it's also what can get us into trouble sometimes. So Alexis, any other questions about that?
Not from reporters. Plenty of community questions. We're going to get to those in a little bit, but
All
we're
right.
already getting a lot of questions.
Excellent. Well, let's
Yeah.
turn to, first of all, our experts here. Dr. Simpson, how the heck are you?
Dr. Stites, I'm doing okay. I'm
Yeah.
working in the ICU this week, which is why I'm all dressed up for our audience here
Well,
today.
actually, this is a pretty good look for you. I think it's when you're at your happiest.
Yes, it is.
It has always been your happy place. To talk to us a little bit about antibiotic resistance and how it's affecting the population, what's going on, why is Kansas so bad, and why does this have the attention of a lot of folks right now?
Yeah, well, I thought I'd start by pointing out what life is like without antibiotics. You know, in 1938, the last epidemiological study pre-antibiotics was done in something called pneumococcal pneumonia, which is, as you know, the most common type of pneumonia, and as Dr. Lauer knows, the most common cause of middle ear infection in kids. But if you got pneumococcal pneumonia in 1938 and you were over age 60, which I think there are a couple of us in this room that might fit that description.
Probably Hawkeye.
If you were over age 60 and you got what we call bacteremic pneumococcal pneumonia, your chances of dying were above 95%. With the advent of penicillin, that was taken down to about 15%. And even if you were younger, your chances of dying were quite high from pneumococcal pneumonia. So antibiotics are really, really important, and they're an important resource that we have to treasure. Now, through the years, bacteria, I'm pretty sure most of our listeners have heard, bacteria have developed resistance to the antibiotics that we have. And so we continually have to produce more and more and more and more. In fact, this is such a growing problem that the part of the federal government that I work part-time in, the Biomedical Advanced Research and Development Authority, has devoted billions of dollars to both new types of antibiotics and new substances that are not antibiotics but might help to alleviate that problem. So the point of this all is, if you get sick with a bug that's resistant to all the antibiotics we have, your chances of dying become quite high. And
So it's
that's what we're
1935
trying to
again, is what you're saying.
come back. We're going back to 1938. Yeah, and we are inexorably headed that direction because bacteria, not that they're smart, they're lucky is what they are. They mutate. All mutations are random mutations, but if it's a mutation that makes the bacteria stronger and better, they will take it and they'll keep moving. So we're headed towards 1938. That's a great way to say that.
Wow. Hawk?
Yeah, I was just going to say, and my boss, Dr. Hinthorn, who has been doing infectious disease
Since
for
before
a long
1938,
time,
I
probably
think.
trained all of you.
Yes, he did.
Sent an article just yesterday about how there are just a lack of antifungal and antibacterial drugs in the pipeline because they are difficult to identify and bring to market. And so that's the other thing as well. We don't have a lot of things that are being able to be researched and brought up in the market also.
Steve, are you under pressure from your patients to prescribe a lot of antibiotics with young children especially?
I think there are times when families just want something fixed. I mean, you hear the story. It was yesterday in clinic. My kid's been sick for a month. You know, they're coughing. They can't be in school. They can't be in daycare. So, especially with families where both parents are working, yeah, there are some times when they're looking for that quick fix that'll get everything taken care of, make sure their child isn't really sick, and get them back into school so they can be back to work. So, yeah, there's pressure across the board for people to get well now so they can get back to life.
You know, one of the things I'm always struck by is that we forget that when you get a cold and you get a virus, those things can hang around for 2, 4, 6, 8 weeks before you feel better. And you think, well, I need an antibiotic. You get some antibiotic. I got better. 2 weeks later, it was just fine. Well, I say you're going to be just fine anyway because 2 weeks passed, and that's a natural history of a viral disease. So, Simpson, how do we combat that? This attitude that I got to have an antibiotic.
How do we combat that attitude? First, we can take some lessons actually from the COVID-19 pandemic that we're talking about. We don't have antibiotics that work yet for that particular virus, and we know that giving someone a penicillin type or a cephalosporin type drug, an antibiotic, doesn't help them get past this viral infection. What we need is for all of our viewers and for all of their friends and for all of their friends to understand fundamentally the way that you and I understand that an antibiotic does nothing for a virus. I think that's a good start. And I think that was your question. How do we get people?
Yeah. How do we do that? How do we just say no?
How do we just say no? Well, this is tough, and I'll tell you something. You alluded to this when you were talking to Dr. Lauer here, is that patients often do exactly what you say. They tell their doctor, I want an antibiotic. And it's quite simply true. We hope this is true, that you have a good working relationship with your doctor, and your doctor wants to maintain that relationship. So if you press your doctor, chances are good that he or she is going to give in for you because they want to maintain that good relationship with you. And so an awful lot of this does come down to listen to your doctor when your doctor says this is a viral infection that won't respond to an antibiotic, and take your side of the relationship and say, hey, I want a good relationship with my doctor too. I should perhaps listen to this advice.
Yeah, so important, Steve. And do people always listen, or they keep saying to you, I want a drug, give me a drug?
Well, most of the time, families and parents are willing to listen, but this is one of the reasons, just to continue what Dr. Simpson was saying, of the importance of having a good primary care physician that you have a relationship with. Because these are very challenging conversations to have with people about the overall public health and the state of antibiotic resistance when somebody's sick. We want to have these conversations, continue this education during those regular visits with either your pediatrician or your primary care physician, so people have an understanding of how this works. When you're sick, I want to feel better too. I want something now, and so we have to continue these conversations as part of this public health awareness for everybody, because the antibiotic stewardship question is going to become more and more important moving forward.
All right, Hawkeye, this is your practice, right? Yeah. You're an infectious disease doctor, you're a medical director of infection prevention control, you've helped lead us through this pandemic. Talk to us a little bit about how do we say no to patients, and what are the indications for when somebody needs an antibiotic and not just time?
Yeah, I mean, I think that is important to talk to patients and let them understand. So that is one of my biggest decisions, and one very obvious question, but not so obvious, that we always ask, my colleagues always ask when we're consulted is, number one, do you have an infection? And number two, if this is an infection, is this something that can be treated with antibiotics? Or, for instance, is it a viral illness? Because we know that there are drawbacks and side effects to antibiotics, yet people want to take them. We know that things like, people, although these are not allergies, people do have nausea, vomiting with antibiotics. These are more side effects. But we know that they can also increase your risk of things like C. difficile infection, which causes diarrhea illness. And those things can be bad, and that can land you in the hospital. And so it's just really up to that discerning physician to really understand, is this something that needs antibiotics? Because we have to understand what are the side effects of those antibiotics if I give them to you. So it's vitally important to give those in the right settings.
It really does make sense. And Steve, I see you shaking your head yes.
Yes. You do shaking my head.
I hear you going, yeah.
Sorry about that.
Are you
Sorry,
meditating?
I am meditating on appropriate use of antibiotics, which I do on a daily basis, by the way. We think hard about this. Now, where I work, obviously, so I have a slightly nuanced perspective on this, because where I work, I take care of something called sepsis, which is when your body's response to infection results in organ damage and quite frequently death. And in that condition, we need to give antibiotics very rapidly. So we have to make a quick determination. Do we think this person is infected, or is this person not infected? And if they are infected, is it something that an antibiotic will be useful for? And quite honestly, we don't have a lot of tools to help us with that, although, again, I feel like an advertisement for BARDA, but that's my job at BARDA, is helping to
Tell us
find
what
the
BARDA
tools
is.
that, BARDA is the Biomedical Advanced Research and Development Authority. It's in the U.S. Department of Health and Human Services, and I actually work in a program there that's called Solving Sepsis. And BARDA is, if you've ever heard of DARPA for the military, we are like DARPA only for healthcare. We are looking for the breakthrough advances and helping to fund some of these smaller biotech companies with some really great ideas. So what they're working on is ways to help doctors do a finger prick a blood stick and say, look, this body response is headed towards sepsis, and it's either bacterial or it's viral, to help us make those decisions. But we don't have those things yet. So one of the things that we do as doctors is that we have to make a decision. Sometimes we wind up giving antibiotics to someone that when the smoke clears by tomorrow morning, we look and go, well, you know what, this probably wasn't an infection, and it's incumbent on us as doctors to understand when that's the case and get the antibiotics stopped as fast as we can get them stopped. And we call that, as Dr. Hawk knows here, we call that antibiotic stewardship, which means we take good care of the antibiotics we've got because we know what can happen when we don't have them.
Yeah, we have a rugged antibiotic stewardship program here with our ID physicians led by Nikki Wilson, and we have Dr. Shoemaker and Dr. Kimball working with our antibiotic stewardship here as well. But I think that was a great point that you make, and that was what I was going to say is too, when people are in the hospital, it's easy for me to come in and look at all the labs, look at all the imaging, and say, is this infection? Because there are other things that can mimic things like infection, and those are immunologic or rheumatologic diseases. If you have rash, it could be, have you been exposed to substance or toxic substances or things like that, metabolic changes. But for someone like Dr. Lauer in the clinic, where he has a clinic visit, it's a lot more difficult. And so he has to be very discerning and take all of the information that's available to him to try and make that decision for that patient.
So Dr. Lauer, let's talk about that.
The other challenge I think we have sometimes is that people don't quite, or children, even parents, their kids get better, they don't finish the antibiotic. The next kid to get sick, and they're like, I'm just going to get some leftover antibiotic. Let's try it out. Talk to us about that.
Well, first off, when medications are prescribed, they really do have set limits on them. We want people to start and finish them as we prescribe them, because we know how they work within those rules. So when people change the rules, cut things short, it starts to affect the outcome of that first patient, the outcome of the second patient, but it also starts to expose bacteria to short courses of antibiotics. And when that happens, what tends to happen is you can start selecting out those resistant bacteria. You start to encourage resistance. So you have to use the tools correctly. all the way through for them to have their desired effect and not start to generate bacteria that are resistant to the antibiotics we do have available for us to use when we need them. Luckily, in my setting, most of the patients are well. I mean, they don't have a serious infection, and making that decision to jump to antibiotics can be problematic. One of the reasons that's true is all the other vaccines that are in place in our medical system that help us prevent serious bacterial infections, the pneumococcal infections, H flu, all these things that we know when patients come into our clinic, if they've been properly vaccinated, they're very unlikely to have, and we can therefore make decisions on what they more likely do have, which this time of year is mostly going to be viral.
Yeah, I think it does make such a difference, and I think we just have to remember that not everything needs a pill.
No.
You know, there are some things that work just fine without a pill, like your body. And then when you need the pill, it's there for you because you're really sick, so you don't want to take too much stuff, create that resistance. And you could create resistance not only through an entire population, because we all use it, you could create it in yourself. And I think that's the other part. You can set yourself up for further failure if you're someone who says, I got to have an antibiotic. Well, the likelihood is you're going to select out that resistant Staphylococcus infection, that resistant pneumococcal infection, and the next time you come along may not respond to the routine antibiotics we use. So beware, be safe, don't be sorry. Alexis, what kind of community questions do we have out there?
We have a common thread that's coming in, doctors. 3 different people have asked similar versions of this one involving antibiotics before a dental procedure. Angela and Vicky and Joellen and Christy want to know, what do you think about antibiotics given short-term before dental procedures? Is that safe? What about after joint replacement? That is common.
Well, yeah, but not unless you need them. There are times when you need them, Hawkeye, and that's when you get them, right?
Yeah, for the general public, the general population, you do not need to take prophylactic antibiotics prior to those procedures. If you have other things like hardware in your body, whether that's a prosthetic joint or a prosthetic heart valve, you need to talk with your medical team that is managing you, and they will keep you up to date on the most recent guidelines of taking probably 1 dose of an antibiotic just prior to that procedure. But it's really that small proportion of the population that has those foreign bodies, those joints or those heart valves or something of that nature. But you need to speak with your medical team about that.
You know, and Steve, one of the things I know that is even in the ICU, we don't give the 2-week course of antibiotics. We've shortened that considerably because we realize we get the benefit without some of the side effects.
That is exactly correct. It was one of the points I hope to be able to bring out today, that through the years, it's fascinating. We started with these long courses and multiple drugs because that's what worked, believe it or not, in tuberculosis. All antibiotics were developed as an offshoot of the fight against tuberculosis once upon a time, and we know that in that particular infection, you got to use a lot of drugs and you got to use them a long time. So we just sort of made a leap. That was way before you and me, we sort of made this
I don't
leap.
know, Simpson. You and I are pretty old.
Well,
It may have been way before.
Well, like dirt,
Hinthorn.
almost. Yeah.
And our great Dr. Lou, who really started the ID program here.
Exactly.
So,
But so we started with long courses, and we have now learned that you can shorten and shorten and shorten. We are now down to, I mean, theoretically, even somebody with septic shock might be well enough treated after 3 or 4 days of antibiotics, believe it or not. I don't think we have the guts to test that theory yet, but nevertheless, it is true.
It does feel that way, right, Hawkeye? I mean, that's kind of an astonishing part. When I was in practice, it was pretty common to give 2 or 3 weeks, and now we're seeing a lot shorter courses.
Yeah, it's great. It's all about reducing antibiotics exposure to help reduce any of those side effects or adverse events, and help reduce active resistance that can occur in those bacteria. Again, your body doesn't become resistant to the antibiotics. It's the bacteria that can become resistant. And one of the main things that helps us do those shorter courses is source control. So things, if you do have an infected joint, or if you have an abscess or pneumonia, it's getting that source controlled adequately to get a lot of that disease out of your body And then the antibiotics come in really and kind of clean everything else up.
And it's funny, kids, they get so darn sick so fast, but then a few days later, who put the nickel back in your box, kid? Sit down a little bit.
Well, that's the nice thing about working with the kids. They get sick quickly, they get well quickly. But this time of year, we're trying to remind parents that, the standard statement is the average toddler and school-age kid gets 5 to 10 colds a year.
Ouch.
They're all viral. They last 2 to 3 weeks each. Most of them are between Thanksgiving and Easter. Let's do a little math. Yeah, they're going to have a runny nose and cough a whole lot of the next few months. What we really want to know is that there are those brief, seems very brief sometimes, periods where they're well. And that's what, if they got that, they were sick all the time versus, well, there was a week there, they were okay. That's the kind of thing we're going for, and the normal viral pattern right now.
Isn't that crazy how many times kids get sick? Which that's how many times parents get sick too.
Well, we also what's really good is how many times they get well.
Yes, that's right. I like that. That's better. Fortunately, it's usually just as many as the number of times they get sick.
Exactly.
Alexis.
Yeah.
I've got some questions from mamas that are worried about their littles and their ear infections. Both Alice and Ashley are concerned. They want to know if they should give their small children antibiotics or ask for them for their ear infections, and they're both wondering, is it safer to let the ear infection run its course if you think your child has an ear infection, and then how do you know if they need an antibiotic or if it's safe to let it run its course?
Alexis, where are you from?
Chicago.
Okay, because my minister church, Shanna Stites, love her, she does a great job, and she says littles, and there aren't that many people that say the littles, and I love it, and she's from northern Missouri, so I just thought,
Ashley said it too. I love it. I think it's sweet.
It is awesome.
Yeah.
All right, the littles.
So
Yeah.
first off, you have to have somebody look at the eardrum. That's, what is the actual infection going on? There's no reliable way of knowing, looking at your kid, pulling at your ear, tugging at your ear, whatever. None of those things are very reliable. You have to have your child's healthcare provider take a look in there. Then they have this remarkable thing called their immune system, which takes care of the vast majority of infections. So this is where we need to set up these discussions with families before their child is sick. We know that most ear infections go away on their own. And we're really trying to push towards this idea of, even if we know they have an ear infection, let's give it 48, 72 hours for their body to take care of it. The child's complaint is, my ear hurts, I have a fever, and we can take care of that with some simple medications, ibuprofen, acetaminophen, that will help with their symptoms. Can we let their body take care of that infection before giving them antibiotics? It's a tough sell right when your kid's sick, if you haven't heard that before, but that's really what we're going to try and get to when they come to clinic, and say, let's just watch this, let your child's body take care of it, which they can most of the time. If that doesn't work, 2 to 3 days still with fever, still sick, then we may need to get in there with the antibiotics, but really trying to stretch out that time before antibiotics are just automatically given.
Alexis.
That's such a interesting answer as a mom of a teenager now. I remember when my son was so little, you feel like they're made of glass, and you take them to the doctor no matter what. You want it fixed right away. It's hard to see them holding their ear. Okay, Jean has asked this question a couple of times. I want to make sure we get Jean's question answered. Jean writes, I've heard since antibiotics are used for only a short period of time, other drugs are used for longer periods of time. Are they not as profitable for the drug manufacturers to spend on development? Does this contribute to the problem? Because antibiotics are not as profitable.
Not as profitable. As it turns out, Steve, and this is something you'll be involved with, the government, I'm sure. Let's not cry for Pfizer and Merck and all these kind of stuff. They have some of the highest margins overall of any business, and I think antibiotics are still a profitable business.
Antibiotics are profitable, but it is.
But it's a great question, by the way. That's a great question.
It's a fantastic question. It's a good question, because if you can manufacture a drug that is also profitable that someone has to take every day for the rest of their life, well, there's a lot more profits in that. So it is true. I agree with Dr. Stites. We should not be crying for the drug manufacturers, but it is also true that those same manufacturers are slowly withdrawing from bringing on new antibiotics because they can direct their monies in other ways that make them a lot more money. Here's a problem I wasn't aware of until I started working in Washington, D.C., and that is that some of the most innovative new antibiotics and antibiotic type drugs that are coming out are coming from smaller companies who can innovate to produce these fantastic drugs, but then don't have the money to put them through the rigorous testing that drugs have to be put through to get them out to the market. And they are people who'd be happy. Hey, I would be happy getting the amount of profits that an antibiotic will give us, but we just can't get it there. So, yeah, that's a very astute question.
So has the
And it
government
is true.
stepped in to help us?
The government has, exactly. As a matter of fact, BARDA, that I've mentioned several times now, has a program called CARB-X, and the entire function of CARB-X is to get companies like I just mentioned on a solid footing to help them to be able to bring these things to be tested and put to the market, because the government has recognized for a long time that this is an issue, and you don't hear a lot of fanfare in the media about this, but your government actually is doing a steady, hard job of trying to help American enterprise actually to come up with what they need to do to help us live better lives.
And I think it's a great example. I know government takes a lot of heat, but let's just say in the public health arena, in the drug development arena, in the research arena like NIH, et cetera, this is all U.S. government at our helping us.
Yes,
and
yes.
they do remarkable work. I mean, these are such good people spending their lives doing this, and there's a public-private partnership in here between government, academic universities, research programs, and PhDs, and all the scientists that are out there researching these questions, and then industry trying to get these things done. And oftentimes these small startups will develop a drug. There's some partnership between the problem. I mean, the cystic fibrosis, think about that. How much profit is there in CF medication really when you only have 30,000 people in the United States who have CF? Not that many. And so how is it that it happened? Well, people raised money. They had a partnership with research universities and the NIH, and they developed new drugs that are now in the process of to dramatically change CF to the point that most people born today will probably have a pretty normal life expectancy. That we couldn't say when I started at CF 30 years ago. And it's such a stunning statement. And that's got to be the things we turn to when we look for drug development.
Yes, yeah, exactly. It is, and it's what's going on. And something else, you just inspired me to say something else. You know, the face of our government tends to be the people at high levels that are
who are fighting with
elected
each other
and
and trying to
directly
get
appointed,
elected.
fighting with everything. I have been so astonished in taking this part-time job with BARDA at the sheer number of truly dedicated, really intelligent people. They just make me feel stupid sometimes, you know, at the amount of intelligence that is there applying their work and their brains to help things to be better this way. I feel in that way much better about it now.
Yeah, whether a Democrat, Republican, or Independent, doesn't matter. Take pride in those things at work. Alexis.
Got a couple questions about long-term antibiotic use. Norma is asking about a loved one who takes antibiotics for 3 to 4 weeks every year because he has a couple of times a year because her loved one has a chronic sinus infection. Is there an alternative? And then Marie wants to know, Marie says she was prescribed antibiotics from her dermatologist for years when she was growing up. We've all heard about this for acne. And she wants to know if that was dangerous and if doctors still prescribe antibiotics for acne. So a couple different ones about long-term use.
Yeah. You know, it's hard to really understand and answer that first question because every individual is so different and really needs to speak with their medical team. You have to understand what is the indication for giving antibiotics and why would you be taking it that long. So it's very difficult to answer that question because I don't know the indication, all the details of that patient. As far as the dermatology, you know, that was common practice. What we heard from our dermatologists that were on the show, I think last week, is that dermatology in general is moving away from giving those. So certainly speak with your dermatologist, but they certainly said that was a common practice, but now I think the field is moving away from giving those again, just from what they said last week on our show.
Yeah, and
Just-
Steve, do you still have young children that you see that are on these long-term antibiotics?
I don't think not as much, and we're trying to understand how to move away from that as just an automatic response of just giving antibiotics, because we know it does cause problems in the long run.
And I'll just say that in the treatment of acne, there's so many more choices
There's better
now.
choices.
You know,
That's the big deal.
20 years
Yes.
ago, very common. Now you can still go on prolonged doxycycline, but you've had to fail other therapies
Yeah.
first.
And I would say if we're talking about doxycycline, there are drugs that I do give and we do give in practice for extended periods of time for certain populations, and those are those people who've had infections in that hardware that we've talked about, whether it's a prosthetic joint that had to get cleaned and washed out because there was infection, but they couldn't remove that joint because they would not be able to replace it. And so we do have people who are on long-term things like doxycycline, like Bactrim, and those do help to keep that infection suppressed so that somebody doesn't lose their leg or have to undergo another heart surgery if they have a mechanical heart valve that's been infected and things of that nature. So there are indications for chronic infections like that. As far as acute infections, for that question that you asked, Alexis, it's very difficult without knowing that patient.
And just to say, I think one of the rules of thumb, one of the principles has been, the harder it is for blood to get to an infection, the longer you need the antibiotic. So if you have an abscess inside your lung, we know that takes a longer antibiotic course, 4 or 6 weeks, as opposed to one that the infection's in a different part of your body where it's easy to get the back. So if you have an abscess, you got a big pool, a pocket of pus somewhere, you got to get the antibiotic in there, it's got to penetrate, you got to really kill all that stuff off. Other times it can be a lot shorter course of therapy. And so, of course, I guess that's why we went to medicine, to study and learn that kind of stuff.
I have some questions that tie into COVID and then also the upcoming Thanksgiving long weekend. Isaac
do it.
has a question. He wants to know if more vaccinations, he's been hearing from some people who are concerned with more vaccinations, if that will create pressure on COVID to evolve resistance to vaccines, just like bacteria and antibiotics.
No.
That's from Isaac.
That is, yeah. No, Isaac, actually, that is a great question.
Good question.
But the answer is no.
Yeah.
Okay.
Yeah, absolutely. I
Hard
would
no.
agree. No.
Hard
what,
no.
What we've actually seen in cell culture is that these viruses develop these mutations and changes on their own without any immune pressure whatsoever. So what is more important is that you continue to have a virus that's circulating in the community, replicating without any immune response. And so that's why the vaccine is so helpful to, number one, decrease the replication in your own body so it doesn't continue to evolve, but more importantly, so it can decrease the spread and the prevalence around the community.
Yeah, just
That's a
remember,
really-
please.
Oh, I was just going to say a really important point, and just to put a specific around that, the Delta virus evolved, from what we can tell, in India well before India had a
Absolutely.
vaccination program. And so just to illustrate exactly what you
Yeah, and
said.
remember, all the vaccines are doing is stimulating your body to produce the antibodies that it would be producing to the bacteria, or in this case, to the virus. And so, if that's the case, then you don't get resistance to vaccination. Actually, vaccination decreases the opportunity for the virus to evolve, and it won't reproduce as much, and that's how we don't get more mutations. That's why it's so important to get so many people vaccinated, Alexis.
Caroline has a question, and this is about something I actually was wondering this too. Is it true you can tell if you need antibiotics by looking at the tissue after you blow your nose, or is that a wives' tale?
No, wives' tale.
What's that?
Okay,
Wives' tale.
there's no truth in that.
We all agree to that. Simpson, wives' tale.
Okay.
If you don't say wives' tale,
I
your
think-
wife's going to come after you. His wife's an ENT surgeon, by the way.
I'll tell you what I'm sitting here thinking. I'm sitting here thinking that's such a sexist thing to say. It's a myth. How about that?
Okay, a
Wives'
very
tale.
good
Oh,
catch.
yeah.
Yep, you're right.
Jeez.
You're
right.
thinking, how do I not get in trouble at home?
Yeah, that's what he's thinking. Have
Happy
you met his
wife,
wife?
happy
I've met
life.
his wife. He's a lovely human, wonderful person, but,
She is fantastic.
she's smart.
But she's the boss.
Smart man. Nate has a question. This is about Thanksgiving and COVID. He writes, my sister-in-law's family had COVID last month, except her husband. 5 days ago, he tested positive from a different source, got infected somewhere else. Because the rest of the family has had it and recovered, what are the odds the rest of the family members are going to carry or transmit the virus? because they're planning to join us for our Thanksgiving gathering, and I need to weigh my risks.
Oh boy.
Yeah.
Interesting.
So,
Yeah.
there are layers to this.
Yes,
So,
there are.
first of all, we have to understand that prior to Delta, we did understand that reinfection was more of a rare or infrequent event. If this infection occurred recently within this past month, even though you had mild illness throughout the household, they didn't say anybody went to the hospital or the ICU, so I assume it's probably mild illness. You probably did mount some response to that. So you should still have fairly high levels of those circulating antibodies that we've been talking about because it's so soon after infection, as well as those T cells as well. So that will help reduce the chance that, number one, if you are re-exposed, you will become infected and you will develop any type of symptomatic disease. Nothing is 100%, but also remember, if you have been vaccinated, there are good studies that show that those people in those households that are vaccinated do have a reduced chance of even getting infected by that index case in that household. And so, again, nothing is 100%. In this scenario here, it feels like there is a probability that is a little bit lower if everybody had the infection recently, that they could transmit and get the infection, but nothing is 100%. And what would add more protection for getting that infection in the household and transmitting it to others if you go to that other gathering is if everybody in that household who was vaccinated who was eligible for vaccination. So not a clean answer, but just understand that your risks are probably lower.
You think if they all did a home test the day that Thanksgiving morning and it was negative, they could go ahead and go?
That is another good thing too. People are wondering how to be safe.
Yeah.
Does testing help? I think that's one more layer that you could add. You could probably try that antigen test, or for more sensitivity in picking up any disease. Although if you recently had it, a PCR test might still be positive.
Maybe still be positive.
But an antigen may tell you, we are looking at the fact that if your antigen test is positive, maybe that's because you are replicating the virus in high enough quantities to transmit it to others, as opposed to if it's negative, you probably aren't. So that is just one more layer you can certainly add.
And a lot of people are using those home tests right now, and
Yeah.
I think there is a role for them. And before in this program, we were always pretty suspicious, but I think you can. I think to your point, if you look at that Swiss cheese model, what are the little places that you can keep trying to cover up a hole so that the disease doesn't get through to you? Socially distancing, masking, vaccination. Home testing probably has a role. I don't think we've really defined it yet. Intuitively, it makes sense, but I don't know that we know exactly how to utilize it. But I would say in that situation where you have something that's positive in your household, the rest of you want to go to Thanksgiving dinner, you don't want to transmit it, you could still be doing that. Home testing, if you got the antigen, can't go. If you don't have the antigen, you're probably okay. But you can't test 2 days beforehand because it's very dynamic as you're around this person in your home. You got to kind of test right before you go.
Yeah.
Just got a really good question from Denise. She writes, I remember being told years ago by doctors and seeing on the news that we weren't supposed to use hand sanitizer too much because it was creating antibiotic-resistant superbugs with all the use of antibacterial hand sanitizer. Well, that's all changed over the past 2 years because of COVID. Everyone's been using hand sanitizer. So are we creating a future disaster?
Great question.
Yeah.
Hawk, Simpson, you guys weigh in?
And I can say I think a lot of it, and I think Dr. Lauer may, also with the fact that he is a pediatrician, I think a lot of it had to deal with one of the components in these antibacterial soaps and possibly in those hand sanitizers, and that was the triclosan, which they did see started to help promote resistance among those environmental bacteria, those bacteria that we come into contact a lot. I think triclosan has been taken out of all those products now, and so really you're just dealing with the alcohol component, and that is really when that alcohol dries is what causes the killing of the bacteria on your hands.
Yeah, the mechanisms by which these bacteria become resistant to antibiotics are within the cell. The way that these hand sanitizers work, you're not going to get resistance to that. It's physically killing the bacteria on contact. So that should no longer be a problem, and keep using hand sanitizers.
But don't drink the hand sanitizers. Don't drink
on your hands.
Yes, don't drink it on your hands. By the way, I wanted to get this in here too. One of the ways that you can combat antibiotic resistance is hold your doctor to be responsible. It's like a knee-jerk response for me these days that if I go into a patient's room, I wash my hands first, usually with hand sanitizer, and as I walk out the door, I wash my hands again.
Absolutely.
But not every doctor thinks of that. I probably think of it because I work in sepsis and I work with really sick people, but not every doctor does. However, that's a great way for us to pass both resistant and non-resistant bacteria from one patient to another if I forgot to wash my hands. So I would recommend that you keep an eye on your loved one's doctor when they're in the hospital, or on your doctor if you were in the hospital, and call them to task.
Alexis,
Say, you didn't wash your hands.
I was going to say, we probably have time for one more question because we're getting close to the top of the hour. So,
You really hit a hot topic. The questions are still flying in.
well, we'll come back to this topic again soon, guys, because this is a
big
great team.
One more question about antibiotics. Marie wants to know about antibiotic ointments, and if it's possible, like bacitracin or those kinds of things. Is it possible to overuse those? Can I still put them on cuts, or should I just do soap and water? And what about acne?
What do you
Putting
think,
it on
Steve
your
Lauer?
face.
Well, number one, soap and water is a great treatment. And getting areas cleaned off and keeping them clean is primary to getting any skin wound to heal, and in fact will take care of most skin wounds. It's just like all of us are saying, you need to go in graded steps. The primary one's keeping it clean, keeping that skin wound soap and watered up several times a day or after any kind of cut happens. Only if you start to see signs of an active infection after that should you be putting on the antibiotics. Do the basic things that work first and keep the antibiotics in reserve for those cases where they're really needed.
All right, let's turn to our guests and get final thoughts from everyone. Dr. Simpson, I'm going to start with you.
Okay.
And by the way, final thought and what you're thankful for, because tomorrow's Thanksgiving.
What am I thankful for? I'm thankful to be here today, quite honestly. Frankly, you nailed it on the head at the beginning of this. I'm working in the ICU this week, and I love that.
Mm-hmm.
And I'm thankful that I've got the capability and the opportunity to do that and to help people out in the ICU. I'm thankful for the boss that you just talked about, my wife. Extremely. I'll stop with those. I'm thankful for a lot of things, and honestly, that's how I've made it through this whole COVID thing, because I just stop and think about what are the things that I'm grateful
Thankful
about.
for. Yeah, I think that's a good
Exactly.
look.
And there are an awful lot of them. The one thing that I wanted to bring up about antibiotic resistance, here's something important. When your doctor gives you an antibiotic prescription and you feel better in 2 days, but he gave you a 7-day prescription, take the whole prescription. One of the ways we promote antibiotic resistance is to go, I feel better now. I don't really need this anymore. And we promote the bacteria that we're trying to treat in becoming resistant. Second thing, if you do have leftover antibiotics, and this opens a whole new can of worms, but if you have leftover antibiotics, don't flush them down the toilet and don't throw them away in the general garbage supply. This is a great way to induce environmental resistance to bacteria. You flush them down your toilet, you have a low concentration of antibiotics now that's in the sewage, and you all know sewage is full of bacteria. And you've got just enough there to allow those bacteria to develop a resistance to the antibiotic that you just flushed. People do this all over America, all over the world, and environmental bacterial resistance is an important problem.
How do you
So I'll
dispose of
stop
those
on
pills
that.
then?
If you take those pills to your pharmacy, I can't say every pharmacy has this program, but most of the major ones do. Walgreens, CVS, they have programs to help you get rid of the leftover things. And how they dispose of them, I'm not quite sure. My suspicion is they probably incinerate them, but I don't know that for a fact.
Cool.
Dr. Lauer, final thoughts?
And thankful.
Thankful for the chance to be working with families and patients and staff to help our patients stay safer and healthier. Thankful for my family and friends I'm going to catch up with this week, and the chance to watch the Jayhawks play 3 basketball games this weekend. So.
Well, there you go. All right.
Yeah. You know, I want to reiterate the salient points by our esteemed guests. So certainly I think as far, when Dr. Lauer was talking about, the best thing to do if you get scratches or cuts is to use soap and water and wash that wound and get it clean, pat it dry, keep it clean and dry, put a bandage over it. If it's a dog bite or a cat bite, please wash it with soap and water very well, and then you probably need to go to urgent care. We know that 80% or more of cat bites really do result in infection because those teeth are like needles and it just injects bacteria down into those soft tissues. But soap and water is the best. You're certainly welcome to put on those antibiotic, those topical solutions, but really soap and water is the best, just as he said. I do, when I walk into the hospital rooms, I do like to have the patients actually see me wringing my hands and drying it from the alcohol that I had just put on prior to walking in. And to your points, Dr. Simpson, antibiotic resistance is so vitally important. You've already mentioned these. So do not request antibiotics if your doctor does not recommend them. We've talked about that. You also talked about if your doctor does prescribe an antibiotic, take the whole course as it's prescribed. And again, also do not use leftover antibiotics from a period time before. We also have some of these infographics from the CDC that we talked about earlier, just about, do I need antibiotics for this? Is it a bacteria? Is it a virus? Remember, most of these respiratory infections are viruses, and you don't need antibiotics. Certainly for that first 10 to 14 days, we do assume it's a virus. And after that, then we can start to say, well, maybe did you get a secondary bacterial infection after that? And that is what these are all available on the CDC. And the last image here just talks about bacterial resistance. So what happens is you start to kill the susceptible bacteria, but there are some resistant bacteria. And unfortunately, if you see in that last octagon over there, I think it's an octagon, the bacteria can actually switch resistance and transfer resistance to other bacteria as well. So it's really all about just trying to understand what happens when the antibiotic gets into your body. It does kill those susceptible bacteria, but there can be some resistant bacteria, and they can further promote other resistance throughout the bacteria. So it's important to really understand all of those things.
Alexis, we're going to split. I know we're changing up the order. I get to have the very last word today after we do a couple of other things. But first, Alexis, that Jess is back with us on Monday. She's enjoying some time off with her family. We know you're going to get to take some time off as well. But I'm going to turn to you now, and you have to first tell us though what you're thankful for.
Okay, I am thankful because you guys, for almost 25 years, I've never had holidays off. I worked in TV news my whole career. And this will be the first time, because now I'm working at the University of Kansas Health System, I actually will be able to spend Thanksgiving and the day after with my family, and
Which
Christmas.
Is awesome,
with my
and we
family.
love having you.
I am so grateful to be here with this incredible team. I'm thankful for you guys. I'm thankful for Jill, who hired me, Jill Chadwick, and I'm just really, this is like a season of joy for me. So thankful for the whole 9 yards.
Yeah.
So Alexis just told us that she started in TV news at age 3.
I have a 15-year-old. But also, what I wanted to show you is I've been doing a little investigative work, channeling my former TV self. I found some actual footage of what Jess is doing right now to prepare for Thanksgiving.
I got to see this.
Take a look at this. This is Jess getting ready for Thanksgiving on the top. That's Jess when people arrive.
I believe that.
Anyone who knows Jess knows this is 1,000% Jess. Even Jess says this is her. So I figure a lot of us can relate to this. Scrambling in the kitchen, all heck is breaking loose, and you open the door. Hi, welcome to our house.
Yeah.
So are you ready to see what we have coming up on Monday before we get to your final thought and
yes, ma'am.
what you're grateful for? Okay. Coming up on Monday, this is incredible. You're going to meet a young man who would stop at nothing to help save a stranger's life. It is incredible. Years after signing up for the Be the Match bone marrow registry, he's called to duty. How a simple cheek swab can save a life. How this guy met a few roadblocks along the way that would have stopped most people. Not him. He finally landed here at the health system, and he shares his message to the man whose life he saved. Levi's story is one that you have got to see. And that is coming up on Monday after a fabulous Thanksgiving weekend. Okay, Dr. Stites.
All
Your
right, here's
final
what I'm
thoughts and
thankful
what you're grateful for.
You bet. I am thankful for this studio, for all the folks here, for the Dol Simons family who has helped make this possible. I'm thankful for my family. I'm thankful for my daughter's in town from Chicago. I'm thankful for the great people we get to work with every day. I'm thankful for all of you, vaccinated and unvaccinated. I'm thankful we get to live in a country where we have that discourse. Many of you know that I love going down to the Ozarks and camping deep in the Ozark woods. You know, it's a funny place in the winter. It's really quiet. All the trees, have lost their leaves, and there's brown is kind of a dominant color. You hear the river, but you don't really hear the sound of the forest as much. And then spring comes, and it just kind of bursts out, and the birds are singing, and the crickets are going, the tree frogs are growing. I mean, the river's going, the things are popping, and there's just this symphony, and all these different voices are out there, and it's hard to hear any one of them. And I sometimes think that's what America's like. You hear all these different voices. It's hard to know which one to always listen to. And I'm thankful that we live in a place where that's okay. But I hope, as you think about this holiday season, you're also thankful for those people that we've mentioned who have spent their entire lives trying to help you in a crisis just like this. Whether it's in the nursing profession, in the ICU, or whether it's in our clinics, or whether it's in the CDC, or whether it's in the NIH, or places where people are doing amazing research every day. And what I'd ask you to do, as you listen to the forest of voices around COVID, that you hear that one that you can really trust. Because what you really want to be thankful for next year is that you're right here, healthy, alive, and able to listen to all the voices. We'll see you on Monday.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.